Today we will review Chapter 12, Client Fitness Assessments, and Chapter 17. So following along with your PowerPoint slides, Chapter 12 explains the importance of client fitness assessments and how to conduct them. First off, it's important to make sure clients feel comfortable, and you are always going to want to share with your clients what they should expect so that they will be on board throughout the entire assessment. That will also help you set expectations. You want to be mindful of which assessments you'll complete based on the client's current fitness level, health situation, and goals. For example, if the client is obese, morbidly obese, you will stay away from things like skin fold or other measurements where the equipment may not measure their data due to them being too overweight. You also would want to steer clear of any high intensity cardiovascular strength assessments if the client is very out of shape or sedentary, and you just want to be aware of what you're planning and make sure that it is exactly what you feel is best for the client in their current situation. Another important note is that you will do most of the listening. The client will do most of the talking. You'll observe things that they're telling you. You'll also observe things they are not telling you, such as body language, how they approach certain assessments, how they move during those assessments, and so on. Lastly, you will use the assessment time to address any client concerns. A lot of clients are fearful, maybe doubtful, discouraged. So it's your time to address any worries that they might have or concerns that they are feeling. Moving on to selection and sequence of assessments. You want to do resting measures first and then move on to cardiovascular assessments. At that point, they'll be warm to do muscular fitness assessments, and at the end, you can do flexibility. So you will guide the selection and the sequence of the assessments. You may do all assessments listed on a certain template that's provided to you by an organization, or you might pick and choose what is necessary to assess. For example, if a client does not care about their weight, you may not take their weight. If a client is not interested in gaining cardiovascular strength and endurance, you may not have them do a cardiovascular test. But let's say they want to gain muscular strength. Well, at that time, you'll place a muscular strength assessment into the program for the day. We'll dive into those assessment details. The first one that you would measure might be height and weight. So this can be measured in centimeters or inches, weight in kilograms or pounds. BMI, you can use a formula, which is weight in kilograms divided by height in meters squared, or you can use something like the Omron BMI equipment. Shortcomings associated with BMI, it's not the most reliable tool, but it is good if you're in a hurry. Let's say you just need some kind of benchmark information to get started. Or let's say you're teaching a group of people where you need to move people through an assessment in a timely fashion. Heart rate is the number of times the heart contracts per minute. You can measure resting heart rate, exercise heart rate, and recovery heart rate. And this will just be dependent on the assessment needs. There's several ways to measure heart rate, which one is manual palpation. Second is using a heart rate monitor or a watch. And third is hooking the person up to an electrocardiogram. Manual palpation of the pulse. You have 3 options. You can use either site at the radial, brachial, or carotid arteries. These are showing you locations. And ways to complete this would be using any of these count types. So you can do a 15-second count and multiply it by 4 to get 60 seconds worth of beats, or you can do a 30-second count and multiply it by 2. Next, we have blood pressure. This is measured in millimeters of mercury. You have systolic and diastolic blood pressure. So systolic is the maximum pressure in the arteries when the heart ventricles contract, and diastolic is the minimum pressure when the ventricles relax. So how much is left over at relaxation. There are 2 terms listed. One is hypertension. That would mean high blood pressure. The second is hypotension, and that is low blood pressure. Table 12.1 gives you a list of classifications of resting blood pressure for adults. It's been updated recently to show elevated measures. So prehypertension would now be elevated. This is on page 320. Going back one slide, I had a few notes that I missed. So hypertension means when resting, the systolic or diastolic pressure or both is chronically elevated. And some symptoms of hypotension would be like dizziness, lightheadedness, and fainting. So measurement of blood pressure, it's an integral component of resting health-related fitness assessments. You'll usually average 2 resting blood pressure recordings on 2 separate days if hypertension might be a consideration. And in order to get accurate readings, the client should be seated and relaxed, and you need to make sure you have the correct size blood pressure cuff. So if the client's been talking to you a lot about their history of exercise, health conditions, they walked over to meet you, etc., their heart rate and blood pressure might be increased. At the time of measurement, you might have them sit down for a few minutes, just breathe, maybe close their eyes, and attempt to relax. If the client might be considered to have hypertension, you will need to refer them to a physician before you train them. Figure 12.4 shows you how the stethoscope head and blood pressure cuff should be positioned. Moving on to body composition. So this is the ratio of fat and fat-free tissue in the body. And we look at the correlation between obesity and increased risk of chronic disease. So the more overweight a person is, the more risk of chronic disease they will have. So getting this information allows you to establish benchmark numbers and help the person set realistic goals so that they can achieve an optimal weight for that individual. You are going to use this information and the table of norms for body fat to help the client set realistic goals again. And the goal is to keep it motivational. So small realistic goals is going to be more motivating than large, long-term, big jumps in weight or percent body fat. Another body composition assessment is the waist to hip ratio. So this is going to show you a representation of body weight distribution. Another important predictor of health risks. So the waist measure is going to be about 1 inch above the navel, and it's going to be the smallest part of the waist. So where the waist indents, almost sometimes right below the rib cage, right above the belly button, about 1 inch above, is where you're going to take the waist measurement. And then the hips is around the buttocks, right at the biggest circumference. So the largest area around the buttocks, and it's above the gluteal fold. At that point, once you get those two numbers, you're going to divide waist circumference by hip circumference, and you'll get a number to see, are they below 0.95 for a male, okay, or are they below 0.86 for a female? Now, if they're above any of those, they would be at an increased health risk. You might measure waist circumference alone. There is a classification of disease risk based on BMI and waist circumference on page 326. There's a table 12.2 that will give you information. But here, if you just measure waist circumference, a woman with a greater than 35-inch waist would be at high risk, a male greater than 40 inches. But you can also have the opposite issue of a very low waist circumference where the female, if she's below 27 and a half, she'd be at high risk. Male below 31 and a half would be considered high risk. Skin folds are on page 329 in your textbook, and this gives you body fat percentage that's more accurate than other ways like testing BMI. It's still an estimation, so it's not going to be spot on. The most spot on is, again, the underwater weighing. But the proportion varies with the person's sex, age, and ethnicity. Procedures for this, you're going to firmly grasp the skin fold site. It's very uncomfortable, so you're going to have to tell the person, you know, that you apologize, but it will be uncomfortable. But you are going to separate the fat from the muscle tissue and clamp the skin fold calipers there. You'll use 2 fingers about 3 inches apart. So we usually use our 4 fingers and our thumb. At that point, you're going to pinch the site and then clip the skin fold calipers right underneath the fingers at the site. You'll hold for about 2 seconds until the tool measures out, and then you'll release it slowly. You'll go to each site once, and then you'll come back around again for 2 total measurements, and you'll take the sum. You'll sum the average of each of those sites. Here are descriptions of skin fold sites on page 328. And page 329 gives you the exact sites. So notice that their fingers and the pinch is right above the calipers. You're always going to place the calipers underneath the pinched fingers. And you'll notice that it's always a diagonal or a vertical fold. Determining body fat percentage, so there's several skin fold formulas available. You can do the sum of 3 sites, which we do here at the Recreation Center, or you can do a sum of 7 sites. And then you'll use a published table to get an estimation. Bioelectrical impedance is non-invasive and it's easy to administer. This is what we can also use with the Omron that measures BMI. but it can also measure percentage of body fat as well. So the basic premise is that the volume of fat-free tissue in the body will be proportional to the electrical conductivity in the body. The analyzer passes a small electrical current into the body and then measures the resistance to that current. So bioelectrical impedance measures total body water and uses calculations for percentage of body fat using some assumptions about hydration levels of individuals and the exact water content of various tissues. So there are several things you need to tell your client before they come in for assessments, and these are like no eating or drinking within 4 hours of the test, no exercise within 12. They need to void all urine completely within 30 minutes of the test, and they should not drink alcohol in the previous 48 hours before it. And this is again because, going back to the slide, we're looking at hydration levels and water content. Those play a role in the measurement. So a summary of body composition techniques is on page 334 in box 12.2. Again, skin fold is going to be your best bet in a normal commercial setting. If you're in a lab or a athletic performance center, you might have the opportunity to use underwater weighing, which is going to be the gold standard for body composition assessments. Moving on to cardiorespiratory fitness assessments. This is basically the ability to perform large muscle dynamic, moderate to high intensity exercise for a long time. So it's going to reflect abilities of the heart, the blood vessels, the blood, the lungs, and the muscles. And this is on page 335. So we use these assessments to have benchmark information again so that we can prescribe exercise that will meet the needs of the client based on where they are in the assessment. It will also give us information so that we can provide feedback and motivation over time. And lastly, it'll give us any prediction of any medical condition. So if we are measuring EKG or we're seeing or observing any issues we might related to medical conditions, we might refer them off to their physician for more testing. And some of these medical conditions could be cardiovascular disease, coronary artery disease, but we would need to further identify or diagnose health problems through their physician. More considerations. So before the person comes into the test, they're going to want to follow this list of points. These tips or these recommendations will be communicated with the client prior to the session. There are different types of tests to predict cardiovascular fitness. We can do a timed completion of set distance, or we can go a distance as far as possible in a set time. For example, a timed completion of a set distance might be a 1 mile for time, where the person should walk, jog, or run. Secondly, maximal distance for set time. You might give the client 12 minutes and they can walk as far as they can in 12 minutes. Some considerations you want to think about is, why am I doing this test? What is the data going to be used for? Your need for accuracy. So is this an athlete, or is there a specific goal related to cardiovascular fitness, or is this just general population? You'll want to consider their age and health status, and then your available resources. So things like, do I have a track? Do I have a treadmill? If I'm going for maximal capacity, do I have graded exercise testing equipment, etc. So we have different assessments. VO2 max is going to predict the cardiovascular fitness level. You have 1.5-mile run for time. You also have a Rockport 1-mile walk test. Another way to assess cardiovascular fitness is using the step test. And you will assess their fitness by looking at recovery heart rate. Moving on to muscular strength assessments and 1RMs. So in this, muscular strength means the maximal force that a person can exert one time. So this is a good way of expressing muscular strength as it's a ratio of total body weight. So you can look at page 12.2 or 12.8 on page 348 for more information. This might be a 1-rep max squat, bench press, deadlift. You'll usually see in the general population group, muscular endurance assessments will be used. And muscular endurance means the ability to apply force repeatedly over time. And there are two common assessments that we use, which are the partial curl up and the push-up test. And table 12.9 gives you norms for those. So your book is a great resource for when you're actually working with a client. Page 351 has a flexibility assessment. So we have the sit and reach test that measures hamstrings, hips, and low back flexibility. And we can use the Canadian trunk forward function test with the sit and reach box. And table 1210 gives you norms for those. So lastly, the client should feel like they've achieved something and feel motivated at the end of the session and when they leave. So making sure that we're setting assessments and protocols up where the client will achieve something and feel encouraged is going to be vital to retaining that client and helping them achieve their goals. Over time, you're going to complete additional reassessments to see if their goals are being met. And if you assess too much, we might not see the changes that we need. So you want to assess, train them for a while, and then when you start to see that their body is adapting, you will retest again. So give them time to make changes. All right, let's move on to chapter 17, functional movement assessments and exercise programming for healthy participants. So with this, personal trainers should be able to understand how motor systems integrate with the body to help a person move well. So we want to develop motor patterns over time. You're going to examine the importance of all aspects of stability, mobility, proprioception within the context of progressive exercise programming. There are three fundamental features of strength and conditioning programs, and these are sensory acuity, optimal stabilization, and mobility. So working with the sensory system and motor patterns, stabilizing muscles around joints, mobilizing others around joints. In many conditions like obesity, overweight, sedentary lifestyle, poor posture, improper training, and aging can impact these features. So first we go into sensory motor control, motor learning. During the early phases of motor learning, performance is largely under conscious control. Motor patterns are stored in the CNS and they become automatic over time and fine-tuned as repetition occurs. So this shows you that to make changes, a client needs to practice repetitive movement, and we need to establish good movement patterns by consistently programming exercises that the client could benefit from. It's another reason why a client might do more repetitions, less sets in the beginning of their training journey with you. That one reason is to establish these motor patterns. Sensory motor system works together to control movement, balance, posture, and joint stability. One term that's really important is proprioception, and it's the sense of knowing where one's body is in space. So you'll notice, let's say for a basic body weight lunge, when you initially teach the client the body weight lunge and they practice, they might be off balance and they might not move very well. That's why we add in progressions to the body weight lunge until they're able to complete the movement with good technique. But that happens with repetition and progression. The client needs to hold static positions as well as dynamic motions. Can we keep certain joints stable while the other ones might be more dynamic during the movement? And lastly, sensory input is gathered from specialized nerve endings. So as you train the client, their brain is sending information down to the muscles to work well over time. And the key point of this is that motor control is developed through enhancing proprioceptive activity and through proper movement patterns, and it all comes with practice. So page 483 shows you this table of sensory input from vestibular, visual, and proprioception, which are integrated within the CNS, resulting in relatively keen body awareness. So we want to start with body weight movement, start with modified movement until the client reaches a point where they're moving well and they've adapted to these motor patterns. From there, we can start progressing the exercises. Stability and mobility. Stability is the state of remaining unchanged, so that's joint stabilization. So let's say in a shoulder press, am I able to keep my shoulders in a stabilized position, or are they all over the place because I'm unable to keep them stable? Okay, so joint stabilization. Some strategies, they're managed at the subcortical level, where the generation of stability is somewhat automatic and requires quality proprioceptive input. The key point is optimal stabilization strategies require a stable base from which forces are transferred. Another one is adequate muscular capacity is required in order to have optimal stabilization. So we need to strengthen the muscles around the shoulder girdle in order to hold positions like an overhead press. We need to engage and activate the core musculature and the posterior chain in order to stay vertical and upright during the shoulder press. So those things happen over time. And thirdly, optimal stabilization strategies require CNS motor programming, so that integration of sensory input. That produces synchronous activation of the muscle. Page 485 gives you table 17.3. It's going to teach you the characteristics of mobilizers and stabilizers. So mobilizers are fast twitch, they fatigue easily, they're superficial muscles, they're relatively small proprioceptive role, they have high force production, they're prone to excess tension and shortening, they are usually in the concentric motion, and they are gross movers. Stabilizers are slow twitch, they're resistant to fatigue, so they can endure a lot. They're the deeper muscle groups, and they're a major contributor to proprioception. There's low force production with stabilizer muscles. They're prone to weakness and inhibition. They are usually used in isometric, so holding, or eccentric, extending, and they're used for joint stabilization. Mediators of proprioception, mobility, and stability. So overweight and obesity and physical inactivity has been shown to be associated with alterations in motor control and postural control. Propensity for inhibition of stabilizing muscles. There's a tendency for certain muscles to weaken or tighten, and this may lead to postural distortion or alterations in motor control. If the person has had previous injuries or they have pain, although the injury may be healed and the person might be pain-free, mobility and stability problems as well as sensory deficits could still remain. So with this, you might notice a person with a previous knee injury is unable to perform a full depth squat, although there's not pain. So you have to reteach that person slowly through safe progressions to get to the squat depth that will work for them. Everyday posture and limited variety of movement, joint structure. So articular geometry and shape and depth of the joints will be a mediator in these, as well as age. So neutral position is where all the joints are stacked. So when you're in a standing position, you're upright, where the ankles, the knee joint, the glutes are tucked under, the abs are engaged, the shoulders are also in line, and the arms are down by the sides. Okay, palms facing forward. So neutral position is going to be important, and it's a common cue that we give to clients very often. All joints being stacked means the joints are in a safe position to move. It also means that certain muscle groups are active in order to stabilize joints and keep them in a safe position while the person moves. So when the spine supports the body with little to no stresses, that means all joints are in a stacked position and the spine is safe, as well as everything else in the body. With assessment and prescription, you're going to establish a movement baseline. So body weight movement is going to be an appropriate place to begin an exercise program. And as you assess, these assessments can assist in learning about the person's static posture as well as their dynamic posture. It'll show you any strengths or weaknesses, maybe tightness, areas of tightness or areas of weakness that you can work on during your program with the client. Establishing a movement baseline, there are different assessments to see, can the person stand in a static neutral posture, and if they cannot, you can find different ways to fix areas of weakness or stretch areas of tightness. With the plumb line assessment on page 490, you'll do this in a sagittal plane and an anterior view. The page 490 as well is going to give you a review of all of the postural corrective suggestions and cues that you can give to a client. Several other assessments for establishing a movement baseline include wall, plank, and roll, page 491. You're going to teach the person how to brace, which means activating the core musculature. You'll also teach the person diaphragmatic breathing assessments and corrective methods. So teaching the client how to breathe from the diaphragm in the beginning of their journey with you is going to help their success long term and help them with the ability to move well over long periods of time. You're going to observe the quality of movement, and that might mean that you're going to need to add more cueing. So one cue could be head in line with the spine. Okay, so checking on are all the joints in alignment. You'll also need to do maybe some instability training where you're going to challenge the client's ability to maintain balance while challenging their center of gravity. So starting with a narrow base of support and moving on to maybe 1 foot on the floor and 1 foot off the floor. Page 497, table 17.12 outlines alignment fault checklist. So if the person has loss of cervical neutral, their head positioned in the front of the body or tilting up or down, okay? Loss of thoracic extension, you're gonna see a rounding of thoracic spine. Internal rotation of the shoulders. Okay, then you have different pelvic tilts. Posterior pelvic tilt is loss of neutral lordosis in the lumbar spine or flattening of the lumbar curve, or the spine, I'm sorry. Anterior pelvic tilt is excessive arching of the low back. So let's pretend like we have a bucket of water right in the middle of our hips. Okay, so if I have a posterior pelvic tilt, I'm going to kind of lean forward here. Now my lumbar spine is flat. But and the water might spill from behind. But let's say I have an anterior pelvic tilt. Now the water is going to spill from the front. Okay, so what we want is to teach the person to have a neutral spine where the water stays in the bucket. Knee valgus is a big one. This is where the knees collapse inward. So usually we're tight in this area. We need to strengthen the weak muscles on the outer leg and glute and stretch probably inner thigh muscles or whatever is tight. Page 500 gives you instability training progression examples. So exercise is listed and the position the client should stand in. And then you will notice that they're mastering the movement if they maintain criteria listed. Self-myofascial release and stretching can be completed using foam rollers, lacrosse balls, rolling pins, and it's a form of manual therapy believed to alleviate discomfort with tender spots and trigger points. So basically the fascia is broken up and now the blood can properly flow through the body, giving relief from trigger points or sore areas. Different alignment issues in soft tissue target. So this one is very helpful. Let's say the person has posterior pelvic tilt. Well, their hamstrings are probably tight as well as their abdominals. So you would want to stretch and foam roll the hamstrings and abdominals. Hyperextension of the lumbar spine shows us that our quadratus lumborum, our quadriceps, iliopsoas are going to be tight. Okay, so again, hyperextension, maybe I'm here, my hips might be pretty tight. So excessive kyphosis of the thoracic spine. This means I might have internal shoulder rotation. Okay, so my pec major and minor might be super tight, lats might be tight, abdominals might be tight, and those things need to be stretched out and released. Lifestyle recommendations. Stability, mobility, and sensory issues may develop over long periods of time. That's why it's important that people stay moving, maintain exercise or physical activity. It's important to recommend changes to lifestyle issues that often result in imbalance. So how is the person sitting or moving at work? How are they breathing? And are they adding in myofascial release like foam rolling? They can change these situations by contacting the camp or their ergonomist at their work site to come and assess their workstation to make sure their posture is in good standing and they are moving safely around their work area. You can teach them diaphragmatic breathing so that they are more aware of breathing and how to breathe from the diaphragm throughout the day, not only during workouts with you. There's a website that can be used to check out functional movement and exercise library. It also has videos, so functionalmovement.com. Have a good day.